Our next presentation is Proliferative Diabetic Retinopathy Surgery, How to Improve the Success Rate by Maria Baracol from San Juan.
Yes, thank you very much for this invitation. These are my financial disclosures. So how do we improve success rate? The main thing is to really reduce complications, and we can do that in a number of ways, including optimizing visibility, controlling intraoperative hemorrhages, preventing iatrogenic breaks, preventing and managing postoperative bleeding, and early recognition and management of redetachment. So optimizing visibility is key, and several things are useful. These include wide-angle viewing systems so that we can see the periphery really well. 3D viewing, as you can see in this video, it not only increases magnification and depth of focus, but it gives you an optimized view under air, which is really key in many of these cases. And using a chandelier helps us see pathology, and particularly for bimanual techniques. Other things that are useful for controlling hemorrhages in particular is preoperative VEGF inhibitors. Ideally, you want to do those 1 to 5 days pre-op. Doing pre-op PRP if it is possible, controlling blood pressure, and using the smallest gauge is really ideal. Not only does it help you control bleeding during the case, but it gives you much more control of the eye. The technique that I like doing, I call it lift and shave, and essentially it is using the highest cutting rate possible and the smallest gauge you're comfortable with, and you alternate after you remove the hyaloid between aspirating to remove the hyaloid and abnormal tissue and then cutting. As you can see in this movie, it is very efficient and it gives you great control. Here's another example. I really like peeling tissue with the probe. The benefit of it versus forceps is that if there is a lot of traction in the underlying retina, the tissue falls back, as you can see there. So the creation of iatrogenic breaks is reduced, which is really a very important key step to avoiding complications and increasing your success rate. So this really gives you much more control, and it is a safer way of peeling tissue. I used to use a lot of viscodissection in the past, but you can do this if you're using 27 or 25 just with the probe. We're doing blunt dissection. You get under the tissue, you blunt dissect the tissue sideways, and then once you have an elevation, you just cut it. And here we're using the probe as forceps to lift, and once we see a resistance, we start cutting and we alternate with that. Preventing bleeding, it is very important to have good closure and good wound construction. And here, I like closing. This is a technique by Andrew Mosfeghi. He closes with a low pressure, and he combs the wounds, and if that doesn't work, then you can always needle the incision. Postoperative bleeding is common in diabetics, especially bad diabetics. You don't really want to take them to the OR, so I always do air fluid exchanges in the office. I think they work over 90% of the time. And in cases where you really suspect bleeding, you can always put anti-VEGFs at the end of the case. Recognizing redetachment, unfortunately, redetachments do occur. I think they happen more if we do not remove the posterior hyaloid completely. If we have missed breaks, it is important if you create a break during the case to mark it with diathermy so that you can see it at the end under air. Any residual traction should be removed, particularly if you have a rhegmatogenous component. If you don't, it is not necessary. And if you have a monocular patient, you can consider silicone oil. I really don't like silicone oil in diabetics, but I would use it in monocular patients. And I'm going to show you this movie. This really shows you all of my techniques together. This is done with 27 gauge, 20,000 cuts per minute, removing the hyaloid. I'm under the hyaloid there. You can see how efficiently the 20,000 probe does this in 27 gauge. Then I'm using the probe as forceps to lift the tissue. And once I encounter resistance, I start cutting. And then I sequentially do that. I aspirate the blood with the probe. I lift it here. We see an epicenter, and then I just use the 27 probe as scissors to cut all the epicenters. It is efficient. You don't have to be changing with instruments. And you see the beauty of this. When you lift it and there's resistance, the tissue falls back. I get under the tissue. I segment. And you can really shave the tissue from the surface if you're using 27. So once I remove all the abnormal tissue, Here, I am aspirating the blood from the surface, and you can see how quickly we really can do these cases, and this is the post-op view of this eye. 6 months later, he attained 2100 vision. So in conclusion, what can I tell you besides these tips? I think it is really important for you, especially the younger people, to embrace new technology. New technology is the future. Don't be afraid of it. Don't stay doing the same things you learned at fellowship. Think outside the box of how you can really adapt new technologies to devise new ways of doing things better. Learn from others, watch other people doing things, and you will learn a lot of tips. And always go to the OR with a plan. When I have an eye, I have an idea of how I really want to approach it. Be meticulous, but always adapt to changing. If your plan is not going as you want it, you have to be very adaptable and just change your approach. And don't lose control of the eye. Control bleeding really well, control the blood pressure of the patient during the surgery, and stay calm. Bad things will happen, but if you stay calm and you think rationally, your cases will go much better. So thank you for your attention.
Thanks, Maria.